Actually, my topic today is going to be the high flexion knee for the clinical outcome at 5 to 6 years follow-up. As we know that the deep flexion is a necessary activity for the traditional Asian lifestyle, and one study showed that for the squatting at least more than 1 hour at the age of 25, we found that about 40% in men and about 68% in women. And when the total knee becomes indicated, the expectation of the patient to get the deep knee bending, especially to accommodate their daily activity, for example, like a kneeling, getting out from the low chair, or sit with the cross-leg style, or sometimes in Thai population, sit in the Thai polite style. It's very concerned among the patient, and they want to get a very satisfaction for the result. So this comes to the current change of the total knee prosthesis. So when we look at the early result and the range of motion of the high flexion knee prosthesis, you can see that the published literature show that it come up with a favorable outcome, come up with a non-different compared to the standard prosthesis. Or when they compare the PS and the CR together, they found that it's quite equal in terms of maximum flexion. So most of study, the follow-up time is about 2 to 4 years, and they do not report the result beyond 5 years. And the key evaluation is a pre and post of comparison about the outcome and the knee flexion. And the other thing is to compare the maximum post-op knee flexion. But none of this study focus in the patient with come up with a pre-operative very good knee flexion or full knee flexion before surgery. I mean, this patient can get a heel to buttock knee flexion. So our purpose of the study is to evaluate the outcome of total knee arthroplasty using the next-gen legacy posterior stabilized flex at a 5 to 6 year follow-up. And the other purpose is to compare the result of the patient who were able to or unable to do a full knee flexion pre-operatively. So we start to do the high flex knee since early of 2003 and until May 2004. This is a consecutive 165 patients and 189 knees. Most patients, we try to fix the patient with very few, not much deformity, and the arc of motion is more than 120, as you can see, and the BMI is not that much. And only performed by myself, and we use the Midwestern approach, and we use the same prosthesis as the single rehabilitation protocol. And the follow-up is a minimum for 5 years. We evaluate for the clinical and functional outcome and some kind of deep knee bending activity, and also the radiographic evaluation. And for the range of motion, the maximum non-weight bearing, passive extension, and full flexion were evaluated by using the goniometers by the mean value of 4 independent observers. And again, for the preoperative maximum knee flexion, we try to find that some patients can get the full flexion. It means that we can get the touching of the heel toward the buttock of the patient. If this patient can do like that, we define to be the group A, and if not able to do, we define as group B. And this is an example in some patients, even though when they do the passive flexion, not touching the heel into the buttock, but when we start to do the anesthesia, we just do a light touching, light force, you can see that the heel can touch the buttock. This we will classify as group A patients. Here is the results of the overall patients. So the mean follow-up is about 64 months, range from 60 to 72. And 9 patients, 11 knee lost for follow-up. So we have 156 patients left, and for the evaluation, the total is 178 knees. And in group A, 51 patients, 60 knees. In group B, 105, 113 patients, 18 knees, sorry. And for the demographic data for the whole patients, male to female ratio, female seem to be much dominant. The mean is about 70, and the BMI is not high like American patient. And when we when we compare group A and group B patient, yeah, we found no significant difference except the male patients seem to be much dominant in group A patients. And here's the variable data, so preoperative, postoperative knee score and function score seem to be much improving. And for the clinical rating, 96% become excellent for rating and 4% become a good for the rating. And compare between the group A and group B, we did not find any difference between the knee. We can get a very good flexion or heel to buttock flexion. And this is the overall range of motion, preoperative maximum flexion 2.5 and post-op about minus 12.2, post-op preoperative maximum flexion 137.9 and post-op maximum flexion 134.8. So the difference is not significant among the both groups. Sorry, this is the both group. And then when we that one is this is the change. Sorry. Yeah, we compare the difference between group A and group B. Group A 60 knee and group B 118 knee. When we look at the preoperative and postoperative range of motion of the group A and B, we found that in group A that can get the heel to buttock flexion, we can find that the maximum flexion will become less and with significant difference. And while group B, the maximum flexion is not different in terms of statistical analysis. And when we are concerned about kneeling, overall is about 15%, so no difference between group A and group B. And again, for sitting in Thai polite style, overall is about 36.5 and no difference between group A and group B. And sit cross-leg style, overall is about 43%, no difference between group A and group B. And for the complication, we have no early loosening related to the implant, but we got one deep infection. We got the two early knee instability at 15 and 24 months, and we need to reoperate and get a thicker polyethylene exchange. For the radiographic result, the mean preoperative alignment is about 8.5 degrees of anatomical varus, and the mean post-op alignment is about 5.1 degrees of anatomical valgus, no radiographic loosening and no complete radiolucent line. And for the discussion, when we look at the maximum passive flexion following the high flexotomy published in the peer-reviewed journal, we can see that the majority of the pre-op is about 100, close to 120 or some a little bit more than 120. But the maximum post-op is about the same, it's about 135. So we think that in our series, we pick the patient that get more knee bending pre-operatively, but final for the result is about the same. And when we look at the clinical outcome following the high flexotomy, we get the poor knee score, poor function score preoperatively, and after surgery, all the patient get a better knee score and function score, and this is going to be very similar to the published study. And for the high flexion knee activity, very few articles published in the literature talking much about the high flexion activity. One study from Kim et al. In JBJS 2008, that they said that the cross-leg sitting is about 64.1%. The other study from Song from Korea also 76%, but in our study we got only 43%. But for kneeling, we also got about 15% less than that published by Song in his group. And then for the sitting in Thai polite style, because this is very unique for our culture, so we got about close to 40%. So this style of sitting is much more common than the other. So when we think about how often do the patient do the high flexion after they underwent the total knee replacement, this study published in the COR 2009 in 20 patients. They monitor the patient for the whole time for the total time close to 36 hours. They found that the flexion of the knee beyond 90 degrees, just about 0.5 of the testing time, and flexion the knee beyond 120 degrees is just 0.1% of the testing time. So this paper concludes that it's very rare to use the deep knee flexion. So for the present study, we also found that the patient had less high knee flexion activity than what they concerned preoperatively. When we think about the early aseptic loosening related to the deep knee flexion, when we look at the literature, only one paper from Han and his colleague published in JBJS in 2007 about 27 from 72 cases, so that is a huge number. But the other didn't show that kind of early loosening. Similar to our result, we didn't find any early loosening related to the use of this prosthesis. So in the conclusion, we found that the total knee arthroplasty using the next-gen legacy flex, we found it provide a favorable outcome at a 5 to 6 year follow-up. We could not find any complication related to the prosthesis. For the maximum flexion benefit, when the patient start up with a very good knee flexion, I mean more than 130 degrees, this prosthesis did not provide improvement of the maximum flexion. But when the patient get a very good or full knee flexion, I mean a heel to buttock flexion, this prosthesis provides significantly decrease of the maximum knee flexion. And about the deep knee flexion activity preoperatively, the patient is concerned about how they could get the kneeling, cross-leg, sitting style, and typewriter style before surgery. But after surgery, we found that less than 50% of them could do that activities. So thank you for your attention.